Hello everyone, let's decode GBS, Guillain-Barre syndrome. So this is a polyreticulopathy which is acute autoimmune and demyelinating disease, and it occurs in a weeks after infections like GI infections or respiratory, and the most common bacteria is Campylobacter jejuni. Then the clinical features are can be motor, sensory, and the autonomic. In motor symptoms, we get like motor paralysis, which is ascending. Then the weakness, which is flaccid type, and the symmetrical, like in both limbs and like that. Then a facial nerve involvement can be there or cannot be there. In sensory symptoms, they are not that marked symptoms. Like in Harrison, they said that the skin and cutaneous sensory disturbances are mild, but the other neurology book said ki this is like absent. So sensory disturbances are not that well marked, and the bladder and bladder involvement can be there or cannot be there. Like if there is a very severe GBS, then bladder involvement can be there. In autonomic symptoms, we get postural hypotension due to vasomotor disturbances, and the cardiac involvement is also seen. In investigation, we see like in CSF, the protein, especially albumin levels are increased, and other cells levels are just normal. Then we do when we do muscle conduction study, they showed demyelinating disorders. And in the treatment, we do like plasmapheresis or IV immunoglobulins. So the most important prognostic factor in treatment is the early detection. As we detect early, so we can start the treatment early. After 2 weeks of detecting the first motor symptoms, IV immunoglobulins are ineffective. So as soon as we can diagnose GBS, we should start the treatment early for the better prognosis. If we are like if someone asked if what are the best in IV immunoglobulins or plasmapheresis, so study shows that the IV immunoglobulins are better than the plasmapheresis, although the effective rate are just normal. But if you have to start the treatment first, so it should be IV immunoglobulins if you are detecting within 2 weeks of initiating the first motor symptoms. Like then the other support treatment like the ventilatory as the respiratory muscle paralysis. Yeah, in the motor symptoms, the respiratory muscles, the diaphragm also get paralysis, so sometimes they need ventilatory support, the tracheostomy, then the skin and cutaneous care also. And in the prognosis, like 85%, 85% of the patient get the recovery, although they are not full recovered, but majorly part are recovered. Then the some other things in GBS is like its type. So there are the 4 types of GBS. The first is acute inflammatory demyelinating neuropathy. The other is acute motor axonal neuropathy. Then acute motor sensory axonal neuropathy. And the fourth is Miller-Fisher syndrome. In Miller-Fisher syndrome, there is like a triad, in which not triad but is a classical symptom which we can remember is DAAO. DAAO. For D is a demyelination, A for ataxia, A for areflexia, and the fourth is the ophthalmoplegia. And the antibody which is seen in Miller-Fisher syndrome is the anti-GQ1B antibody. There is another disease called Bickerstaff encephalitis, where the antibody is same GQ1B antibody, and the symptoms are the same. Just only one difference, that in Miller-Fisher syndrome we get areflexia, where in Bickerstaff encephalitis we get hyperreflexia. Okay? Then the other like autoimmune neuropathy, we get anti-GM1 antibody, and in the motor axonal neuropathy we get GD1A antibody, GD1A antibody. So the definition: cause, clinical features, investigation, treatment, then prognosis, and the types and the antibodies. This whole summarize the GBS.